Show Ahmedabad. My name is Dr. Rajiv Sankaranarayanan. I'm a heart failure cardiologist from Liverpool, United Kingdom. Thank you to Dr. Kamal Sharma for inviting me to talk to you all about a newer device therapy for heart failure. I shall be talking to you about cardiac contractility modulation and baroreceptor activation therapy. These are my disclosure slides. So I shall be telling you why we need alternative or novel device therapy in heart failure. I shall start off with the role of cardiac contractile modulation, baroreceptor activation therapy or BAT. I'm sorry, I did not want to mention coronavirus, but I will be talking about BAT today, and also go through the current evidence and future directions. So if you look at the background, heart failure has a significant morbidity and mortality. There are around 26 million people with heart failure worldwide, we think. And of these, the vast majority, 80 to 85% of patients with heart failure are not suitable for device therapy such as CRT. And of those who receive CRT, up to a third are non-responders. So they don't feel any better even after CRT. There is therefore a need for novel device therapies, particularly for the above cohort. And of these, CCM, which is cardiac contractility modulation, and baroreceptor activation therapy, are two such new therapies. So we'll start with CCM first. So what is cardiac contractility modulation? So this involves delivery of precisely timed energy pulses to the heart, and this is through application of relatively high voltage, so 7.5 volt, and this is around 10 to 15 times or more than the traditional pacemaker impulses. Long duration, about 20 milliseconds, of biphasic electrical signals, which are applied to the right ventricular septal wall during the absolute myocardial refractory period. This device actually received FDA approval in 2019. And this schema represents the signals. So we can see that the signals are biphasic. They are relatively high voltage, like I mentioned. I mentioned the duration of 20 milliseconds and the fact that the signals are non-excitatory because they're applied during the absolute refractory period, as we can see. So the schema also shows us the artifact on the ECG trace through application of the CCM signal. And this schema also shows us what the device involves. So it is a rechargeable implanted pulse generator, and this can be rechargeable, and that extends the battery life to well more than 5 years. So the need for device changes is minimized. And like I said, the CCM signal is applied during the absolute refractory period, and this is standard pacing leads. Now, the first version of this, the first prototype of this, used the atrial lead for sensing, but the newer versions, as I'll come to, have actually removed the need for atrial sensing leads. So it is mainly the two ventricular leads, one of which is for sensing, the other is to deliver the impulse. Now, the biological effect of these stimuli is seen very rapidly in the region of signal applications. And these translate ultimately to improved peak VO2, improved symptomatic status, and reduced heart failure hospitalizations. The other biological effects are also seen remotely over time. As I mentioned, the two right ventricular septal leads, one for sensing and the other for CCM delivery. And how do the signals produce their beneficial effects? They affect the biology of failing myocardial genes. The heart failure the heart failure genetic phenotype starts to appear like the fetal heart genes, and what CCM does, it restore it to the adult functioning heart genotype. And so this is in terms of the genes, but also it affects proteins and phosphorylation, and this translates to improved function, ultimately to increased contractility, and all these are achieved without an increase in myocardial oxygen consumption. This slide shows us some of the effects of CCM seen in terms of LV reverse remodeling, and this has been demonstrated by 3D echo studies both in animals but also in humans, seeing that the beneficial effects on reverse remodeling are seen within 3 months of initiating the CCM therapy. I mentioned a bit about the timing of effects. So the rapid effects are seen within minutes or hours, and this involves local electronic spread of the signal, rapid phosphorylation of the key proteins, the contractile proteins involved in calcium signaling. So this leads to improved calcium cycling and contractile force, and all this without increased myocardial oxygen demand. Some of the intermediate effects, these take hours to weeks, and this, like I said, there's a shift of the gene program from the failure or the fetal type to normal, and these local effects improve contraction at a global level. And there are longer term effects taking weeks to months, and these translate to beneficial effect on global ventricular properties as well as reverse remodeling. What is the impact of CCM and how is this achieved? And this is through multivarious effects. So, like I said, it improves intracellular calcium metabolism, improves diastolic calcium levels, and this ultimately leads to phosphorylation of myofilaments, increased small heat shock protein, tighten phosphorylation, and distensibility is increased. So, these improve the contractile properties of the heart. These also CCM also leads to reduced oxidative stress, reduce cardiac fibrosis, and reduce sympathetic nerve activity. And these ultimately lead to improved systolic reserve and diastolic filling and improved quality of life and symptoms. And these are some of the clinical trials. Quite a few of these were done many years back. This goes back to more than 5 years back. But if what we'll do is we'll focus on the phase 3 trials, and that is looking at the FIX-HF trials and the FIX-HF 5C, which are more recent. But in total, over or nearly 1,600 patients with heart failure have been studied as of date, and there are currently several other trials as well, looking at the role of CCM in patients with HFpEF and in combination with ICD therapy as well. So, as I said, we'll look at the landmark FIX-HF randomized control trial, which studied CCM. So this compares the control and the active arms, and we're looking more at the FIX-HF confirmatory trial, which followed the FIX-HF trial itself. So this included adult patients, and because the FIX-HF trial showed that the benefit was largely seen in patients with an ejection fraction of 25 to 45%. This was estimated by echocardiography. So this trial looked predominantly at this cohort of patients. These were well treated and on optimal medical therapy. It is important to also look at some of the exclusion criteria. And this includes if their baseline peak VO2 is less than 9 or more than 20, if there is a correctable cause of heart failure. This could be valvular, this could be congenital, this could be if the patient is awaiting a bypass or PCI, or also if they already have CRT in situ. Patients on inotropic support were excluded. Those with a large ventricular ectopic burden or who might have a pacing requirement, that is, if they have a PR interval which is quite prolonged, were excluded. Also important to remember that this trial excluded patients with persistent or permanent atrial fibrillation. Obviously, patients whose exercise tolerance is limited by condition other than heart failure were also excluded, because exercise tolerance is one of the outcome measures for this trial. Those with an MI within 90 days of enrollment, those with the previous heart transplant, ongoing dialysis, or mechanical tricuspid valve, because these leads are put in across the tricuspid valve like a traditional RV lead for a pacemaker, a Brady pacing. So the primary outcome measure was very impressive. CCM, or cardiac contractile modulation, significantly improves the peak VO2. And these are some of the secondary outcome measures, but not less in importance. So we want our patients to feel better, live longer, and stay out of hospital. And these outcome measures looked at the quality of life, so significant benefits seen in the CCM group, and also looked at improving NYHA class. So we can see that the CCM group had a 60%, close to 60% improvement in the NYHA class. And this is another secondary outcome measure, and this looked at the composite of cardiovascular death and heart failure hospitalizations. And we can see that in the CCM arm, the Kaplan-Meier curve shows that the CCM arm diverges from the control arm close to about 2 months. So around that time, we can start to see a significant benefit in terms of reduced cardiovascular death and heart failure hospitalizations. So what is the current evidence for cardiac contractility modulation? So the patients who have ongoing NYHA class 3 and some studies have also included ambulatory class 4, and this is despite optimal medical therapy. Those with narrow QRS, so those who don't have left bundle branch block would traditionally benefit from CRT. Ejection fraction between 25 to 45%. So this includes HFrEF, but also some patients with heart failure with mildly reduced ejection fraction. And like I said, there are ongoing studies looking at benefits in heart failure with preserved ejection fraction. We await those in the next year or two. And it's important that at the moment the evidence is restricted to those with sinus rhythm, but we don't know if the effects translate to those with AF at the moment. So that needs further evidence to be generated. So this is a flow chart which shows this. So essentially, we have a large cohort of patients who don't have left bundle branch block morphology, and even in those with left bundle branch block, the evidence is restricted to benefit seen in those with a QRS duration of more than 120 milliseconds. Sorry, 130 milliseconds. So there is a large cohort of patients who, if they have ongoing symptoms despite guideline-directed medical therapy, who could be suitable for CCM, and this could be with ICD therapy as well. But we also have a cohort of patients who have had cardiac resynchronization therapy, but have to have ongoing continued symptoms of NYHA class 3 or ambulatory class 4, who can be considered for CCM as well. And what does the future hold for CCM? Like I said, combining CCM with ICD therapy is something that we could see a lot more in the future. And we await evidence for the benefit in heart failure with preserved ejection fraction. There are ongoing trials, like I mentioned. So now let's move to the other novel device therapy, which is baroreceptor activation therapy, or BAT. And this works on the premise of carotid baroreceptor stimulation. And what does that lead to? That leads to inhibition of sympathetic activity, and we see a sympathetic overdrive in heart failure, which is seen as a compensatory mechanism. So this methodology basically leads to enhanced parasympathetic activity and reduction in sympathetic activity. And what are the physiological effects that we see on the heart and elsewhere? We see a reduction in heart rate. So these effects are comparable to that seen due to beta blockers, for example, but also other heart failure prognostic therapies. So improved effects on remodeling, increased vasodilatation, effect on lowering blood pressure, improved diuresis, reduced renal secretion. And this is the actual device itself. So this is the carotid sinus lead, which is a 2 mm electrode, 7 mm silicon backer with a unipolar design. So this is the device. Again, it's an implantable generator which has a 4 to 5 year longevity. So in terms of the lead itself, it is the function of the device is the location is around the carotid sinus basically, and that is to achieve carotid baroreceptor stimulation. And like I said, these are some of the effects, and that those effects are achieved through a reduction in sympathetic activity, but also due to an increase in parasympathetic activity. And this is the programmer we can see for our programming, but also telemetry signals. So I'll focus in the next few slides looking at the BEAT-HF, which is a phase 3 multi-center randomized control trial, which demonstrated both safety and efficacy of this device therapy. So what were the key eligibility criteria for patients included in this RCT? Patients with predominantly NYHA class 3, smaller proportion of patients had class 2, and also recently class 3. This included patients with severely impaired LV systolic function, left ventricular ejection fraction of less than 35%, who've had a 6-minute haul walk distance of 150 to 400 meters, elevated NT-proBNP or previous heart failure hospitalizations. Looking at those, these are on stable optimal medical therapy, those traditionally who would not have been suited for CRT. And important distinction between this trial and those where we studied CCM was that this trial included patients with atrial fibrillation, and also those who had implanted ICDs. So this is looking at the baseline demographics between the baroreceptor autonomic therapy versus control group, and we can see that they're largely representative of the heart failure population that we see. Slightly younger population, perhaps. Patients with a mean age of around early 60s in both arms. Definitely significant underrepresentation of women, and again Caucasian predominance. Majority, like I said, NYHA class 3, Some of the other physiological parameters are, were definitely comparable. Heart rate perhaps could have been better controlled in both arms. Um, uh, LVEF comparable 27 and 28%, so significantly impaired left ventricular systolic function. Elevated NT-proBNP, preserved renal function in both arms. About 30 to 43% of patients had atrial fibrillation in this study, and a significant proportion, close to 50% in both arms, had had previous heart failure hospitalization. Now, this slide is quite remarkable. It compares the use of baseline therapies. So, this was a very, very well treated population, a large proportion of patients who were on ACE or ARNI, 90% or above on beta blockers, 50% on MRA in both arms, well treated diuretic with diuretics. And again, this is quite important to note, close to 80% of patients in both arms had implanted ICDs. So if we look at the symptomatic improvement, so these were the different outcome measures. So if we start from the left side of the screen, so we're looking at improvement in quality of life. There was significant improvement in quality of life through use of baroreceptor autonomic therapy. This led to improvement in exercise capacity as well, and this translated through improvement in NYHA class. And we can also see that this trial, and this is comparable to paradigm HF, which showed that even a 10% reduction in NT-proBNP leads to significant reduction of cardiovascular death and heart failure hospitalizations. This trial actually showed that there was a 25% reduction through use of BAT. Safety, the device was well tolerated with no significant events, and received FDA approval also in 2019. So if we look at the composite evidence for both device therapies, the current evidence is largely for HFrEF, particularly in patients who are not suitable for CRT, or this could be for CRT non-responders. CCM, there was some benefit seen in patients with heart failure with mildly reduced ejection fraction as well. And like I said, there are ongoing trials for CCM looking at the role in heart failure with preserved ejection fraction. There is not yet evidence for CCM in patients with AF. However, the trials for BAT or baroreceptor activation therapy have shown that the evidence extends to those with atrial fibrillation as well. So it's important we keep trying novel solutions for heart failure. I'd like to end sharing something that we'd like to learn from from one of my favorite recent series, which is Patal Lok. And this is not just so some of these things that we see, the novel therapies, are not something that's just WhatsApp video pada tha. It's important that we keep trying some of these novel solutions. Like I said, a large proportion of heart failure patients are not suitable for conventional device therapy like CRT. So CCM and BAT could be the jugaad for this proportion of patients. Thank you very much.